Good morning, everyone. My name is Radwa Mustafa. I'm an internal medicine resident at Sheikh Khalifa Medical City, Abu Dhabi. I'm originally Egyptian. It's a pleasure and an honor to stand here and present to you one of the cases I've encountered in my clinical practice. Pyrexia puzzle, take a closer look to solve the mystery. We present to you a 64-year-old lady of African descent. She's a known case of IBS. She presented with fever, nausea, and abdominal pain for 3 days. She was febrile and tachycardic upon presentation with mild generalized tenderness over her abdomen. The following were her initial laboratory tests with a CRP of 273. CT abdomen pelvis with contrast was done, which showed mild wall edema along the sigmoid colon with fat stranding and minimal free fluid. She was admitted as a case of infectious colitis for antibiotic administration and IV hydration. Straightforward, right? Let's see. Gastroenterology was involved, and the following GI workup was done, which all came back negative, including sigmoidoscopy with a sigmoid biopsy, which was unremarkable. By 1 week, we expect this patient to be improving and getting better going home. Unfortunately, our patient is still spiking fever. She's too weary and lethargic, and she's unable to tolerate orally. So far, she's received 1 week of IV antibiotics without any improvement. As you can see, not a single day without a spike of fever. As for her lab workup, lipase is normal, negative procal, normal lactic acid, and no growth on any of her cultures. Let me show you her CRPs fluctuating around 250s, never coming down to normal. In view of her unresolving symptoms and persistently elevated inflammatory markers, we consulted infectious disease unit, and the decision was to stop antibiotics. By now, we knew something was unusual, and so we started working her up for fever of unknown origin. The following infectious workup, as you can see, plenty of it, negative. And then we started thinking, could this be a malignancy in view of her age and persistently elevated inflammatory markers? CT thorax and neck, no lymphadenopathy, plasma cell neoplasms were ruled out, bone marrow biopsy with flow cytometry and culture, unremarkable. Our patient was planned for a PET CT scan, however, it was taking some time to arrange as it was out of house. And so we spoke to our radiologists asking them, personally I called them, I said, can we do anything for my patient? She's miserable. I receive a call 3 hours later saying the following: upon review of her CT abdomen pelvis, there is a rim of inflammation around the abdominal aorta, and this is a normal CT just for you to contrast. If you allow me to show you a video of the extent of involvement, this was extending all the way down to her mesenteric bifurcation. The following autoinflammatory workup was already done during her hospital stay, as you can see, all of which is negative. However, her ESR was elevated at 115. And although most of the inflammatory workup is negative, ESR and CRP were elevated. So if we're dealing with large vessel vasculitis, that would be elevated. Which brings us to 2 large entities, giant cell arteritis versus Takayasu arteritis. Our patient did fall in the age group of giant cell arteritis. However, she didn't have any cranial symptoms and no proximal muscle tenderness. As for Takayasu arteritis, it's usually in younger females below the age of 40. It's known as pulseless disease. Our patient had equal beautiful pulses, no discrepancy in blood pressure between any of her limbs, of course. So to reach a diagnosis, we decided to proceed with MR angiography to take a better look at her blood vessels. An MDT meeting was conducted. MR angiography revealed involvement of the aortic arch and the roots of the arch vessels, of course, along with the thoracic and the abdominal aorta. If you allow me to show you, here is a more zoomed-in picture, and this is to delineate the rim of inflammation in the aortic arch. Diagnosis of extracranial GCA was made, and our patient was started on 3 days of pulse steroids. Let's see the response. Within 24 hours, my patient is out of bed. She's no longer nauseated, abdominal pain has resolved, and her fever has completely subsided. This was honestly wonderful to see. If you don't believe me, take a look. Denoted by the blue arrow is when we started steroids, no more spikes of fever. As for her CRP, almost down to normal. Our patient was happy to be discharged on 40 milligrams of prednisolone, followed by a tapering regimen. And here's the missing puzzle piece, autoimmune. Let's conclude. So extracranial GCA requires a higher level of suspicion due to the absence of the well-known cranial symptoms. Some clues, if now we look in retrospect, persistent leukocytosis, thrombocytosis, anemia, as well as raised inflammatory markers. These were also noted in other retrospective studies of other GCA patients with a positive p-value. Also important to know that our patient scored 3 points on the 2022 GCA classification criteria. I'd like to point that the sensitivity for the isolated large vessel vasculitis is only 62%, which means if you follow this criteria strictly for diagnosis, you would miss out on more than 1/3 of the patients. Finally, temporal artery biopsy is the gold standard for diagnosis, but as the years pass, the sensitivity has reduced. Angiography now is great for diagnosis, and it can be effective in up to 67% of the patients. Complications, as most of you know, aneurysms and dissection, and medical management is about glucocorticoids and glucocorticoid-sparing agents. These are my references. Thank you very much. Happy to receive questions.
Thank you, and thank you for observing the time.
Thank you very much.
So now we move to the discussion. Roman?
Well, again, a little bit more light. Go. Third row. Maybe I will ask the first one. Usually in those cases, you go for 5 minutes and then you say, we did a PET scan. Did you do a PET scan here?
We wanted to. So our hospital doesn't have a PET scan. Our patient was not insured. We were going to send her for another facility. I couldn't wait. I was the direct resident. I was seeing my patient every single day, suffering for 3 weeks. I called the radiologist. I remember saying, give me anything. Let me please know what's going on with her.
This calls being patient's advocate.
2 questions. In one of your slides, if I'm not missed something, you said that the blood pressure levels were different in each arm. Did you miss that at the very beginning? Did you make a full physical exam?
We did, multiple times. No, I have checked her arms, her legs, equal pulses. We've done a Doppler on her. We've done everything. There were no discrepancy in any of her blood pressures, no claudication whatsoever, extremely warm extremities.
Okay, and the second, sorry.
Go ahead, of course.
And why did you start antibiotic at first? And why did you prefer ciprofloxacin and the tigecycline? What's the rationale behind that?
So,
of course, infectious disease stopped that immediately, though. What was the reason for that?
So initially, we were covering for possible GI bacteria, and that's why we started with ciprofloxacin. We were thinking that this is infectious colitis. With the presentation and the CT findings, we were more towards infectious colitis. So it was more of an empirical therapy. And then we spoke to our infectious disease unit. That's when they suggested up it to tigecycline for more broader coverage to include everything. And then we saw that it's not working out. That's when we decided to stop. I hope I answered your questions. Thank you very much.
Over here.
Yes.
So is the extracranial vasculitis and cranial vasculitis the same disease?
So it's a extracranial versus giant cell arteritis. That's your question. Yeah. I'd like to see it as a spectrum of diseases. I've done a lot of reading on the topic. So I would say that patients can come into like a spectrum of presentation. Some of them present your usual with the blindness, the visual loss, the jaw claudication, the temporal headache. These are the easiest to diagnose, and these are actually usually picked up in the shortest time. And then comes the patients who come with severe claudication, stenosis, that's on the other spectrum. And then comes my patient in the middle, constitutional symptoms, fever. Those are the ones which are tricky. So it is treated the same way. It is diagnosed, I would say, a little differently, because with temporal arteritis, like the GCA, which is cranial, you get to do the color Doppler ultrasound, you get to do biopsies, which in my case was not feasible, I couldn't do. And in the ones where it's extracranial, you depend more on angiography, but treatment is almost identical.
I'm Maggie Larche from Canada.
Nice to meet you.
Thank you, great case, and one of my favorites, as I'm a rheumatologist. A couple of teaching points on this, I would say, is the CRP was really high. Usually in GCA, we expect a CRP of less than 100, so having it at close to 300 was unusual.
Agreed.
And of course, I think most of us would have gone for infection first as a cause of that high of a CRP. A clinical question to you is what, on examination, did you hear any bruits? Was there any, no bruits at all?
I examined her with a rheumatologist, actually. So
Yeah.
I've examined her myself, and then I called the rheumatologist, and I said, you know what, let's do this, right?
Yeah.
No bruits on
Nothing.
examination, no.
Yeah, yeah. Okay, thank you.
Thank you very much.
All right, we have to stop here.
Thank you
Very
very
much.
much. Thank you.